Yeah, good morning. My name's Sarah. I'm a staff nurse at the Royal Berkshire Hospital in Reading. So I work in an acute elderly care ward, and it's normally an acute elderly male ward, mainly dementia. But for the last couple of years, we've been a COVID ward as well. So we're now a mixed ward, and we only take hot patients, COVID patients, and then as they reach the end of their 10 days, they move off the ward. So that's changed things a little bit in the last couple of years. So I'm going to be talking about the impact of nutrition on healing pressure ulcers. So obviously being elderly care and dementia and the sort of conditions that we get in with pneumonia, stroke, all sorts, a lot of end-of-life care as well. We get a lot of people coming in with multiple pressure sores and also, unfortunately, also developing pressure sores on the ward as well. So just going back to what Anita was saying, you know, a lot of us in the acute sector as well, you know, especially being the in a COVID ward as well, I think we're starting to get a bit dissatisfied. And those of us who are staying, I think we're probably staying through sheer stubbornness. But you know, I love my job and I want to stay, but I think we feel that things want to change a little bit, and we feel like it's a bit of a Groundhog Day, you know, where people are coming in, they're getting pressure sores, kind of half treating them as much as we can, and then they're going to you guys, to care homes, and it seems to be just all the same. And it'd be lovely if things could change over the next few years and we had a different approach to things. I'm really passionate about nutrition, and I don't think that it is recognised as such an important part of health and healing. I also don't think that many healthcare professionals are aware of how much nutrition can help with wound care either and healing pressure ulcers. I think part of this is how much training we get. You know, I remember in my nurse training, I think we got maybe a couple of hours of nutrition training over the 3 years. And I've recently chatted to my colleagues who are doctors and asked them, you know, how much training do you guys get, you know, as doctors? And they laughed at me and said, we get a couple of hours over 6 years. And they said it wasn't really tangible, it wasn't really practical advice about how to actually deal with conditions, how to actually make a difference to patients. So yeah. Okay, a few things. Pressure ulcers are caused by tissue damage when the blood supply to an area of skin is impaired because of significant pressure, most commonly on bony prominences like sacrum, heels, spine, and elbows, and also through oxygen tubing, catheters, and things like that. It is estimated that 110,000 new pressure ulcers develop each year and cost the NHS between £1.4 and £2.1 billion annually, or more than £1.4 million every day. That's about 4% of the NHS's total expenditure, and that's hugely significant, I think, considering it's something that's largely avoidable. The average length of a hospital stay was found to be around 25 days with a person with a pressure ulcer, or 5 to 8 days extra per pressure ulcer. And pressure ulcers in older patients was associated with a 5-fold increase in mortality. So that's huge. Malnutrition is a common complication in wound healing and is cited by NICE as being a key factor in the development of pressure ulcers. Okay, so I won't dwell on the science bit, but I'm sorry, get your science hats on for just a few minutes, I'm afraid, okay? So I'll give a quick rundown of normal wound healing and how it's impacted by certain key nutrients, just to give it some context. For wound healing to happen, a sequence of events needs to happen to restore the damaged tissue: hemostasis, the inflammatory stage, the proliferation stage, and the tissue remodeling stage. And then there's a few of the main nutrients: energy, protein, fatty acids, iron. You've got some micronutrients. There are micronutrients obviously involved, but these, I'd be chatting for longer than 20 minutes. So these seem to be some of the key nutrients that are involved with wound healing, and then obviously fluid. So the first stage, hemostasis. Blood platelets come into contact with collagen and clump together to form a mesh that clots the wound, stops bleeding, and forms a barrier against microorganisms, and creates an environment for cells to move into the area. So Extra energy is obviously needed at this stage with carbohydrates and fatty acids and protein. Iron and micronutrients are all needed for proper immune function as well in that first stage. So the difficult stage, inflammatory stage. So we seem to see a lot of wounds that just get stuck in this stage, and they're just flipping between slightly getting better, and then they'll come back into the inflammatory stage, and then they're a lot of exudate, and they're very hard to manage. And I know a lot of you who are in care homes and residential homes, I know that leg ulcers is another bugbear for you as well, even more than us acute staff. So similar thing. So in this stage, lots of white blood cells like leukocytes rush into the wound area. These inflammatory cells, like neutrophils, monocytes, and other white blood cells, kickstart wound healing and release enzymes that start getting rid of waste. Macrophages help these cells clean up all the cell waste and attract other inflammatory cells to the area, and also release growth factors that trigger cell-building cells, fibroblasts, to build new tissue. So again, extra energy is needed at this stage for extra cell activity. Protein is essential for proper immune function and for fibroblasts rushing into the area at this stage. Inadequate protein at this stage will just keep the wound in the inflammatory stage, and it's very hard to progress beyond that. Fatty acids are essential for the development of inflammatory cells and hormones. Iron is needed for proper immune response and for transporting oxygen into the wound. And a deficiency in iron in this stage can affect cell proliferation, joining together, and protein synthesis, and regulating white blood cell function as well. So vitamin C, E, and A are all so vital for immune function. And vitamin C is needed for monocyte migration into the wound, the white blood cells coming into the wound, and also helps with iron absorption as well. Zinc and copper needed for white blood cell proliferation as well, and also protein synthesis. And fluid is just important for all wound stages, just to create a nice moist environment as well. So if they're lucky, they get to the proliferation stage. This is when angiogenesis occurs, where new blood vessels are formed, fibroblasia, where new fibrous tissue is made, and re-epithelialization, where epithelial cells will be restored. And this better structure makes it possible to transport fluid and nutrients into the wound so that granulation tissue can finally be made. So again, extra energy is still needed, as well as extra protein for repairing tissue by making collagen and for angiogenesis. Fatty acids are essential for the synthesis of cell membranes. Iron, vitamin C, and vitamin A are needed for collagen synthesis. Zinc and copper for epithelialization and for forming granulation tissue. And vitamin E is also important for forming new tissue as well. So then, tissue remodeling stage. This is when they build scar tissue, and it's just to get, the goal is to get the most tensile strength in the skin through reorganizing and breaking down of that matrix that was built. And again, energy, protein, and micronutrients will all be vital at this stage as well. So there's a few other factors that impact wound healing that are related to nutrition. So obviously pain obviously affects patient participation, how much they will accept dressing changes, which I find most often that can be a huge barrier to wound care as well. But it also can affect their appetite, which will affect their food intake as well. So nutrition can also impact the central nervous system and affect a patient's perception of pain. And a study was also found that a patient's gut health status can affect a patient's perception of pain as well, which is really interesting. So age is another important factor. Our older patients are more likely to have multiple conditions that affect things like their hand dexterity, their cognitive function, their incontinence, mobility, their ability to swallow, and these can all affect their appetite and their food intake as well. Mobility obviously can affect whether they shop or cook or attend meal times as well, and also can make falls and then hip fracture more likely, which obviously will affect their, which will also exacerbate the problem and make pressure sores more likely as well. So incontinence, I'm sure we've all met that lady. Lots of them who refuse to drink anything beyond lunchtime because they don't want to get up in the middle of the night to go to the toilet, and that can obviously over the course of the day will impact their fluid intake as well. And cognitive impairment, apart from just forgetting to drink, I think a lot of them are relying on us carers or family members to cook for them or shop for them, and it may not be at a time when they're actually hungry, and they won't get their heads around necessarily eating for convenience at a time when it's convenient, so they may not eat at those times. Income and lifestyle. So loneliness can be a really big problem, especially in older people. It can contribute to low mood, which obviously can then affect their eating habits. It was found in a study that social support, isolation, and participation in leisure activities were closely linked to the quality of a person's diet. Access to healthy meals and knowledge of what a healthy diet is. So the British Nutrition Foundation, that only a third of us adults get our 5 a day. So probably none of us who are on shift get that. So increased food and living costs. We're all affected by this at the moment, obviously. But for somebody who's on a pension, I believe that it's just been increased. The basic state pension has just been increased to just under £142 a week, which is not very much. If you take all the other energy costs or other bills or other costs that they have to pay, that doesn't leave a lot for food. So that can affect how much they're willing to spend on a healthy diet or how much they can spend on it. And people on lower incomes can have similar issues as well. And it was also found that people on lower incomes have lower vitamin C levels in general. So the European Pressure Ulcer Advisory Panel has made some recommendations for what is needed to heal a pressure ulcer. So for energy, they recommend that the wound requires 30 to 35 calories per kilogram of body weight per day. So let's say we have a 70 kilogram patient, that would be 2,100 calories. That doesn't sound too excessive, but for somebody who has those barriers to their nutritional intake, like I've just mentioned, that can be really hard to achieve. And if someone's got a condition perhaps like COPD, those energy needs might be even higher. So that's something to bear in mind. For protein, it is recommended for a category 2 pressure ulcer that the body requires 1.2 to 1.5 grams per kilogram of body weight a day. So again, for our 70 kilogram patient, that would be 84 grams, at least 84 grams of protein a day. And for category 4 pressure ulcer, where it's a lot deeper, that was up to 2 grams per kilogram. So for our 70 kilogram patient again, that would be 140 grams of protein needed a day. I don't know if I could manage to get 140 grams of protein in a day without a lot of support, let alone somebody who's got those barriers to their intake. And finally, for food, 30 to 40 mils per kilogram body weight. So again, for our 70 kilogram patient, that would be 2,100 mils per day. So obviously in my acute trust, we're fortunate to be able to give IV fluids, to be able to support their fluid intake. But obviously in the community, we have to support that orally instead, and that can be really hard to achieve. If someone's been sent home with thickened fluids, that's always the bugbear, and nobody wants to drink them, or general swallowing difficulties, or incontinence, or cognitive impairments. So that can be really difficult to achieve. It was also suggested, going back to protein, that protein needs to increase by 250% in all stages of wound healing. So that figure could actually even be higher, depending on the circumstances. So speaking of fluid intake, the risk of dehydration is a lot higher in older adults, not just because they may not drink enough, but also because older adults have a risk of sarcopenia, so reduced muscle mass. And if you have decreased muscle mass, the amount of water stored in the body is less, since more water can be stored in muscle, not fatty tissue. So this can delay wound healing as well. If someone has reduced body mass, their protein intake needs to be higher because they need to rebuild that body mass and heal the wound at the same time. So that would delay the wound healing. A study found that with a loss of 10% lean body mass, muscle mass, immunity was impaired. With a loss of 20% lean body mass, decreased wound healing and thinning of the skin occurred. And with a loss of 30% lean body mass, wound healing was stalled and an increased likelihood of new wounds were formed. So I know that the figures vary, but with an older person of 70, 80, if they spend just a week in bed, a large percentage of their body mass can be, lean body mass can actually be lost in just a week. So that's something to bear in mind. And studies have also shown that that lean body mass that is lost over being bedbound for even a short period of time, that's mainly in the lower limbs. So obviously that just exacerbates the problem because it makes falls more likely and mobility. And so excessive exudate can lead to protein deficiency. So actually, if that wound is stuck in that inflammatory phase, it can induce a catabolic metabolic effect, and it will just break down protein in the body and make that protein deficiency even more. So for a lot of people, they might need extra support. The European Pressure Ulcer Advisory Panel recommends high-calorie, high-protein, arginine, zinc, and antioxidant oil supplements should be prescribed for patients with a Category 2 or more pressure ulcer who are malnourished or at risk of malnutrition. Yet, NICE recommends that nutritional supplements are not required to treat patients with a pressure ulcer if nutritional intake is adequate. Well, I find that quite ambiguous. And what is adequate? We've just learned that actually protein intake, protein needs and energy needs are a lot higher for patients who are, have a chronic wound or like a pressure ulcer. So we can't just rely on our subjective viewpoint on what is adequate. If someone's just finishing their meals, that still might not be adequate to actually heal a wound. So just something to think about there. Some research has been done on the effectiveness of our oil supplements like enteral drinks. Significant improvements were found in pressure ulcer healing from arginine, protein-enriched supplements. Also, omega-3 supplements were found to reduce ulcer size and depth and limit deterioration of the wound. In the study so far, no significant healing from zinc. That could be that it wasn't combined with other nutrients as well. So obviously, more research needs to be done, and more importance needs to be leaned towards nutrition in order for more research to be done, I think, as well. But it's a promising start. And also it's been suggested that all supplements, obviously they're really expensive, but if they reduce dressing changes by improving wound healing, then that can improve wound care costs overall. So it's just about being probably more proactive rather than reactive in our response. So malnutrition doesn't always equate to a low body weight. I have to mention this. Obesity has been linked to impaired wound healing. There's a few reasons for this. Obese patients typically have a lower lean body mass and higher body fat ratio, which can lead to a protein deficiency in the same way as I mentioned before. So obesity can also cause scale ischemia in the excess subcutaneous tissue. This is due to poor circulation in adipose or fatty tissue, which can result in reduced collagen synthesis and reduced ability to fight infection. Also, growth factors in fatty tissue can cause a low-grade inflammation in the body, which can affect the body's immune response even more. And it was found that obese surgical patients have a high number of macro and micronutritional deficiencies. In addition, things like skin folds can contribute to moisture damage, and also people who are obese and have extra health conditions can have limited mobility as well, which can affect pressure damage. However, as you can see, we use the MUST score. I'm not sure if you use that in the community. I think it's pretty widespread. Malnutrition Universal Screening Tool. Anybody who has a BMI of 20 and above gets a score of 0. So if you've got a BMI of 30, 35, 40, you score a 0, which leads you to think that actually somebody who's obese has a low risk of malnutrition, but that's not always the case. So I hope I've highlighted a little bit more about the importance of thinking about nutrition when it comes to healing pressure ulcers, and in fact all chronic hard-to-heal wounds. It's really important to recognise the barriers to effective nutrition, especially when someone is healing a wound and has those extra nutritional requirements to deal with. And also to think about assessing someone's nutritional status properly, and to refer to the dietitian and to use those support to actually get an adequate nutritional status, nutritional status for someone. In our trust, our tissue viability nurses, our wound care nurses are really good at referring or advising referral to the dietitian when someone has a pressure ulcer. But I don't find that other healthcare professionals necessarily are. Us nurses as well, and also doctors, we're not that good actually thinking about nutrition when it comes to wound care for our pressure ulcers. And I think just to think probably beyond wound care as well. I hope that in the future we think more about nutrition and a bit more proactively maybe. I think maybe something can change over COVID perhaps, and actually we sort of have a bit more of a proactive stance on people's healthcare, so that we're not just trying to just heal these wounds blindly, and actually try and move nutrition into a bit more of a focus for things like autoimmune diseases and diabetes. The research is coming out all the time, obviously, and it'd be lovely to get it a bit more in use for us healthcare professionals. I find that probably one of the reasons I am hesitant, and my colleagues are hesitant, to actually kind of recommend to patients or junior colleagues about nutrition, is because there's not that official protocol there to say. And I think until you've got that official guidelines there and an official sort of pathway to follow, we're starting to develop one in our trust actually for nutrition and wound care just now. But until that happens, it can be quite hard to actually have that confidence to actually pass on to patients. So thank you for listening.